He did medical school at Washington, D.C. at Howard, his residency at Cook County in Chicago, and then his fellowship just nearby at Beth Israel in Boston. And he joined us as faculty in September. And this morning he'll be talking to us, as you can see, with the evolution of surgical critical care. Thank you.
Good morning, everyone. It's a pleasure to be here with you today. Again, Dr. Page. I met many of you guys, especially the residents, during my time on ACS, trauma and the ICU, but looking forward to meeting many more of you as colleagues and to work closely with you guys. Excuse me. There we go. Much of this talk will center around the historical context of how critical care came to be in the US and kind of around the world, and kind of what forces, what figures played a driving component in how we experience modern ICU care today. All right. As a disclaimer, I plan to keep this presentation pretty succinct, but hopefully you can walk away today with some knowledge that you didn't have beforehand. So just briefly, we'll talk about me, a little bit about who I am, where I came from, a little bit about the evolution of critical care in history, where we stand today in the 21st century, and where I think it might be going thereafter. And then notably, we'll talk about a few clinical pearls for the ICU management of patients, especially for our more junior residents who are in ICU. And we'll close it off with some questions. I have no disclosures. So about me, kind of Dr. Amy spilled the beans a little bit, but if you recognize a few of these images right here on the screen, this is where I come from. It's quite far from New England and it's much warmer. This is actually San Antonio. Yes, I'm a Texan. They have a saying down there that everything is bigger and badder in Texas, but to that, I will say on acute care surgery, the gallbladder patients have it much worse here. So I've seen some of the worst acute cholecystitis in my early career here in Rhode Island, but whatever doesn't break you makes you stronger, right? So during my time in Texas also, before medicine, many of you guys may not know, but I was in a totally different career path. I spent a number of years in the healthcare fitness industry, and I helped clients transform their health in a different way. Working as a performance enhancement specialist, working as an MMA practitioner, a teacher, and those kind of components of working closely with clients and kind of understanding where they come from kind of permeates to how I treat patients today. So I launched my medical career by first starting off in DC. In 2015, I was at Howard, the nation's capital, and it was such a privilege to be there, to be among some of the brightest minds, serving the underserved communities that were pretty prevalent around the area. And so I think that's where I take away some of my passion for treating the underserved populations and healthcare disparities. It was also at that time that I developed an interest in surgery. And some of my mentors in surgery, like the late Dr. Lori Wilson, who was a surgical oncologist, and a traumatologist, Dr. Edward Cornwell, kind of helped motivate me to go in that direction and really pursue surgery. And so I moved yet again and went to the Midwest, in the west side of Chicago, and experienced quite a bit of trauma there in Cook County, but it was a wonderful experience, good clinical exposure. I didn't know it at the time, but Cook County was pretty historic in the advancement of medicine throughout history. There's a series of firsts that happened there, such as the first blood bank in the early 1900s, the first trauma center that was comprehensive in the 60s. The first open heart surgery happened there in the late 1800s. But it was such a privilege to spend time there. And it's where I developed an interest in traumatology and emergency general surgery, carrying out that training and rounding it about at Beth Israel in Boston. Most excitingly, I'm here before you today as part of the trauma division. I'm pleased to work with some of the brightest minds like Dr. Amy and Dr. Monahan, our new Dr. Portlatine, to treat some of the members of the community. And it's my goal to continue the legacy of high clinical excellence that's here. Not only that, but to educate some of you guys, our residents, in our future in surgery and medicine. As a first-gen physician myself, I think that's kind of one of my driving duties. And I will be also serving as the surgical liaison for the incarcerated population, the ACI. On a more personal note, when I'm not operating and when I'm not in the ICU, I like to enjoy traveling and experiencing different cultures. Just two of these pictures. There are many. I just put it up here for you guys, but me and my wife had a chance to visit Montreal for the first time when I first moved to New England, and we're huge fans, by the way. On the left is the Notre Dame Basilica, which is one of the old Gothic revival style cathedrals in Montreal that was made in the early 1800s. And if you're looking always for good pictures, go there first because they have excellent paintings. It's very picturesque, quite serene. You'd enjoy it. And then if you're interested in looking at views of the city, I would go to the Grand de Rouge, which is on the old port on the picture on the right. I get great views of the city skyline, and it's a good time. So just a little plug for Canada. So with that being said, we're going to jump right into the evolution of surgical critical care. Does anyone know who this person is? Students, residents? Well, if you're unfamiliar, this is a kind of a key figure who launched it all in critical care. This is actually someone who was born in the early 1800s in Italy. Her name is Florence Nightingale. She was a nurse who trained in Germany and Paris, France, which was kind of contrary to the social constraints at the time. But she trained there, came back to England, and became a force to practice in her field. And during the mid 1850s is when the Crimean War broke out. And, there were a lot of wounded British soldiers that needed care. And her role kind of got injected into it when the Secretary of War commissioned her to take leadership of several nurses, like a group of nurses, and really optimize care for soldiers. And she's credited for actually having created one of the first makeshift ICUs in history called monitoring units. In these monitoring units, she would basically work on improving sanitation, nutrition, coordinating care efforts for the British soldiers. And one account says that she had decreased mortality from 40% to 2% in 6 months. Those are staggering figures, but I don't know if they could be corroborated. But the thought is there, the early makings of ICU. Moving into the 1920s, we have this gentleman on the left who is considered to be one of the pioneers in neurosurgery. His name is Dr. Walker Dandy. Of his numerous contributions to surgery and medicine, he's created the air contrast ventriculography, whereby you can find lesions in the brain. He's kind of been credited for aneurysmal clipping of brain aneurysms. But notably for our discussion, he's also credited for the first ICU in America in 1923, where he created a 3-bed ICU, whereby nurses and practitioners can monitor these post-operative neuro patients. It was kind of a forerunner to the modern ICU in America. And on the right is a picture of him and his what he calls the brain team, caring for one of his patients in his ICU. Moving over to the 1930s and 40s, something significant happens in our world. We're actually in World War II. And the picture on the left is showing an early version of what we call a shock ward. And so this was kind of a pivotal moment for practicing critical care components like resuscitation, because in the picture in the middle, you'll see that providers are charged with the task of giving plasma, blood transfusions, and fluids to optimize patients before sending them to higher level care. So these are all components that we see in our daily practice of surgery and medicine in ICU that's being demonstrated here. Moving into the late 1940s and 1950s, the world is hit with another big event, and that event is the polio epidemic. The polio epidemic was pretty severe, in which some cases were plagued with severe respiratory failure. And at the time, the standard of care was negative pressure ventilation with the iron lung. And in places like Denmark, where those resources were limited, there was a physician called Bjorn Ibsen, who was a Danish anesthesiologist who trained at MGH in Boston and came back, who has been credited for the use of positive pressure ventilation. And so as an anesthesiologist, he actually did tracheostomies, and he'd put trachs in patients, put a rubber cuff tube in, and he would have a team of volunteers or workers manually pump patients 24/7 to keep them alive. And so some of the data showed that over the 70 patients who were who had severe respiratory failure, about several thousand people, over 165,000 hours, manually ventilated these patients and dropped the mortality rate for that patient population. So he was also credited for creating what's another version of the ICU. He positioned these patients in dedicated wards so that they can continue having positive pressure ventilation. And he had the vision of having low patient to nurse ratios, which we see today in modern ICU care. That's a picture of one of his patients who has a trach, and you could see actually the manual pump by the patient's arm, which is kind of fascinating. Moving into the 1950s and then 1960s, Mayo over here in America establishes the first post-op ICU for open heart surgery patients. It's one of the first surgically focused ICUs that was created in America. And over in Baltimore City Hospital, Dr. Saffer, who's an anesthesiologist, was credited for the first multidisciplinary ICU that involved round-the-clock physician coverage. He's also credited for being a pioneer in CPR and ABC resuscitation, which is interesting. But by the late 1960s, most major hospitals had at least one ICU per hospital. Further measurements transition from intermittent measurements of vital signs to more continuous. As you can see, with right heart catheterization was developed, central venous pressure measurements were developed. And then there was a transition from negative pressure ventilation to positive pressure ventilation as more advanced ventilators were developed. And that was kind of more ubiquitous throughout the world. And then we can see that concepts of ventilation, such as atelectasis, positive and expiratory pressure, and ventilator-induced lung injury started to be more recognized. In addition to Dr. Saffer, on the left, you have Dr. Max Harry Weil, who's considered to be one of the founding fathers of modern ICU. He created the first 4-bed shock ward in LA County in the 60s. And you have in the picture in the middle, Dr. William Schumacher, who was a surgeon, intensivist, scientist. These three minds came together and kind of coined the idea of critical care, which is a collaborative effort by physicians of different specialties so that they can focus on treating critically ill patients. And so in the 70s, they came together and actually made a society, which is still to this day pretty prevalent. It's called the Society of Critical Care Medicine. Further advancements in the field, such as Swan's catheter use and pulse oximetry, became developed. Interestingly, during the 70s, also the first successes of VV ECMO by physician traumatologist, Dr. J. Donald Hill, in 71, saved his first patient, who was a motorcycle accident patient, who was like in the young 20s, from respiratory failure by using VV ECMO. And then VA ECMO became first successfully used in 75, where a patient neonate who had a meconium aspirate was spared with its use. Moving into 1986, we finally arrived at surgical critical care, being formally recognized by the American Board of Surgery as a subspecialty. Um, and, and moving into the 20th and 21st century, we see that further advancements kind of help shape where we are today. So starting with ARDS, it's common, it's almost like second nature to us in how we treat this, but in the early 90s, we were still having a lot of question marks on how to best approach this. So ARDSnet was created, and by 2000s, the first trial, the ARMA trial, put out that low tidal volumes could be one of the defining factors of how to manage ARDS. And then by the 2010s, the alveoli and FACT trials looked at the benefits of optimal PEEP, conservative fluid management, and further optimizing ARDS recovery. Looking at sepsis in the early 90s, we come with our first definition. And then by early 2000s, the Surviving Sepsis campaign was launched with subsequent iterations of its guidelines. And then notably, we were all affected by COVID in 2020, but in 2021, the guidelines came out for how to manage critically ill COVID patients, with also an emphasis on post-ICU care. And then lastly, just to harp on this, but fluid resuscitation in the early 2000s saw a shift from using static measurements such as CVP to more dynamic measurements, such as using your pulse pressure variation, your velocity time integral, your passive leg raise, vena cava diameter variation, all these modalities to show that the advancement in technology is helping us care for our patients better. So where are we today? So we walk into the ICU on the 5th floor, and what do we see? We see modern critical care that's more multidisciplinary, team-based approach. In centers that do it well, you'll see that it's not just surgeon or intensivist driven, but you have people like respiratory therapy. You have people like the nurse, the patient's nurse speaking up. You have people like the therapy team, physical and occupational, all working conjointly to improve outcomes in your patients. We commonly use adjuncts now, like your POCUS, for your bedside procedures, such as line placements, paracenteses, thoracenteses, looking at heart function, and then really relying on some of those adjunctive therapies like ECMO and such to continue to care for the most critically ill. Areas of growth in the early 1970s, I'm not sure if you are aware, but we actually had the advent of tele-ICU. At that time, it was audiovisual links that were kind of helping flew in practitioners from afar that care for people in the ICU. But it wasn't until the 2000s and 2010s that this kind of became more popularized. I think that this has still a role to play in the modern ICU. Actually, at Yale, not too far from here, for the past decade, they've been using this at their community hospitals to kind of bridge the shortage of intensivist gap, to provide more coverage at night, more in the rural settings. So I think that there's a place and a time for tele-ICU, and I expect that it's going to be continue to be used. And then looking forward into the age of AI, as we are here in a technological age, I see that we're with our advancements and the predictive models that AI has been kind of looking into, we could possibly detect decompensation earlier. We could look at detecting sepsis faster. Actually, in 2022, one of the studies that came out, which was the TRUE study, was developed by some researchers at Hopkins. They looked at machine learning-based support to detect sepsis early and routinely collected health data. And so it was a prospective trial, although, and they found that an 18% adjusted relative risk reduction occurred in hospital mortality if the practitioners in the hospital utilize this resource. There's much work to be done to kind of iron out the details, but I think that's kind of where we're heading with ICU and with care at large, is using our our learning algorithms to help make better decisions and faster decisions. So kind of moving into the second component of the talk is some clinical ICU pearls. One of the first things I'd like to talk about is actually hypernatremia. And I know you guys, especially the younger residents, you see this all the time. Oh, the sodium is 154. What do I do with that knowledge? And then we kind of muster through it. But again, this is a common issue in the ICU. Usually happens in a setting of inadequate fluid intake. There's two types. There's acute, there's chronic. Whether if it's occurring less than 48 hours or greater than 48 hours in duration. And actually, in most cases, people are actually chronic because they've had an insidious rise in their sodium all along. But there's the signs and symptoms of the patient who has this is either they can have no symptoms at all, or they can have slight symptoms like thirst or GI losses, or more severe symptoms like lethargy, seizures, coma, etc. The three categories of hypernatremia is based on a volume status. If you're hypovolemic, you can have this from burns, basically losses of fluid from your body like GI, respiratory, osmotic. Euvolemic, you could have a more severe case like diabetes insipidus, central or nephrogenic, and then hypervolemic, where you're taking in a lot of salt uh, for whatever reason. So to look into this more, you would first grab your labs. You would grab your chemistry panel. You would get your lights, your urine lights, your osmolality. And then from there, you would kind of first confirm if the patient actually does have hypernatremia, looking at your labs. Then you would have to get a sense on what their volume status is. You could use your physical exam, such as, do they seem dry? Do they have dry mucous membranes? What are their vital signs showing? But notably, you can lean on your labs too to help provide some support. So their BU and creatinine ratio is greater than 20. If their FeNA is less than 1%, or their FeUria is less than 35%, then maybe they might be volume down, and that might clue you into a hypovolemic hypernatremia. Next, if you have your urine osmolality, I would look at that next to see if ADH is responsive. Does the kidneys have the ability to concentrate the urine? And so if your urine osms show that you're less than 300, or it's less than the plasma osmolality, then you'd be wondering if there's an issue with the concentrating ability of the kidney. And so you would then figure out, is it a DI that's responsive to ADH versus not? If your urine osmosis is greater than 800, then there's no issue with concentration. So you might either have an issue with just volume. You would then move on to figuring out your water deficit with the equation on the screen. And then you would start moving into each of these areas of how to management. For example, hypovolemic hyponatremia, you would first want to resuscitate your patients with some isotonics before you transition to things like D5W or half isotonic to correct your deficit. You would account for your insensible losses by adding a little more volume. And then you would want to lower that sodium less by 8 to 12 milliequivalents a day to avoid cerebral edema. So you'd be checking your BMPs every 4 to 6 hours. With euvolemic hypernatremia, you would also correct that deficit in the same manner. But for DI, that's central, you would give DDAVP. You can either do this IV, intranasally. It could be done as an infusion to help treat this. Nephrogenic, on the other hand, doesn't have any medications that will reverse the resistance to ADH. So you'd want to DC causative agents that cause this. If there's meds that the patient's taking that might make them have a proclivity to this. or they might be even in the polyuric phase of ATN. And then plus or minus thiazides to increase the urine osmolality. And then lastly, for hypervolemic hypernatremia, you would want to correct the deficit. Again, as mentioned, stop salt intake and consider diuretics as well. The next common thing we see all the time in the ICU is hyperglycemia. As you know, normally patients live between 60 to 120 if they're healthy, via the ability of the body to give insulin out and for the target tissues to utilize it. And so in the ICU, we know that prolonged hyperglycemia is associated with poor outcomes. So you have issues with infections, issues with wound healing, bacteremia, UTIs, pneumonias, all these things have an association with this as well. And we know specifically if you're looking at how things work, it affects the way your PMNs travel to target sites. It affects how macrophages do their complement fixation. It messes up how you put down your scaffolding to heal your wounds. So it's something that needs to be focused on. So etiologies of this, obviously diabetics, certain meds can cause this, TPM can cause this, the stress response, ramping up, gluconeogenesis in the liver. All these things kind of play a role in hyperglycemia. Notably, the Nice Sugar trial that came out in 2009 is kind of one of those landmark trials that kind of shaped how we manage ICU sugar management, hyperglycemia management today. It was basically a multi-center retrospective control trial, basically kind of comparing a more intensive version of glycemic control, keeping a patient between 80 to 108 versus the conventional less than 180. And they found that by just keeping it less than 180, you had less associations with hyperglycemia, comparable mortality rates, and overall did better with a more liberal approach. The last two areas I'd like to highlight are DKA and euglycemic DKA. It's common things we see in the ICU. As we know, in diabetic ketoacidosis, this can happen in any diabetic, but commonly metabolic acidosis and ketosis. Patients who present with this might have some nausea, some vomiting, some abdominal pain, polydipsia, polyuria. They might be obtunded, have seizures and coma in the more extreme variant. But to work this up, you would first get, again, your labs. You would get your chem panel, your lights, your urine, look at your urine ketones, your beta hydroxybutyrate, your blood gases, and your EKG to confirm an anion gap, metabolic acidosis, volume contraction, and potassium deficits. And so this can be found on the Epic Clinical Resources tab under pharmacy guidelines. The one that we have in the ICU is not as up to date. That's hanging on the wall, but this is the most recent one back in 2025. And just to kind of highlight that the two of the components, obviously you need to replete your electrolytes as you go along, but for fluid replacement, you want to first resuscitate these patients because they're so volume down from the osmotic diuresis that you would start with your isotonics. starting with at least 2 to 4 liters of LR, so it's a bolus first to get them more euvolemic, prior to considering on putting them on a maintenance fluid. You would use the corrected sodium and glucose level to kind of determine what maintenance fluid to use. And so that's in the next slide. For example, if your corrected sodium's 140 or more and your glucose is less than 250, you'd use D5 half versus half NS. And conversely, if it's less than 140 and less than 250, you'd use D5 NS or D5 LR. Moving to the IV insulin therapy, you would first kind of look at your potassium and make sure if it's less than 3, then you're not giving any insulin. You would first replete the potassium. But if it's 3 to less than 5.3, you would start with either a long-acting insulin dose or their home dose, whichever is less. And then you would start the infusion at 0.1 units per kg an hour of insulin. And you'd be continually checking your blood sugar levels every hour, looking at the blood glucose to determine what fluids you're going to use. And then the criteria for resolution is if the bicarb is greater than 18 and the anion gap is less than 12, or is at baseline. Just a brief word on euglycemic diabetic ketoacidosis. I think this is something that can potentially get missed. I know many of us, we don't think about this unless you're like combing through the patient's chart, looking at the medications they're on. But one of the risk factors for this is obviously the SGLT2 inhibitors, and patients who are on that, who've been fasting or they've been exercising for a long time. And then you'll see a patient who has near normal plasma glucose levels with a mild hyperglycemia and ketoacidosis. So it's more insidious than your standard DKA. So looking at the pathology, there's a carbohydrate deficit, there's less insulin deficit and resistance, but there's an uptick of the counter-regulatory hormones that result in ketosis without significant change in how glucose is being made or used. And so you'll have the patient who has similar symptoms, but a little bit milder, where they're having malaise, anorexia, tachypnea. They might be less dehydrated, given the absence of the polyuria or polydipsia. And you'd work up the patient in the same way with labs such as BNP, glucose, lights, beta hydroxybutyrate, or BBG. And so the management is also online. There's also a good resource that you should look at in the clinical resources tab. But just to kind of highlight it, you would start with an insulin infusion at 0.1 units per kg an hour based on their weights. You would figure out the initial dextrose dosing on if it's less than 150 of your blood sugars, and you would bolus 25 grams of D50 and start with a D10 W maintenance rate at 100 an hour. And if it's between 150 and 200, you would start D10W at 50 an hour. You'd be getting your BMPs Q2 hours, you get your sugars every hour, and then you would try to maintain euglycemia with the IV fusion per protocol. And it's listed right here. But to know that you've achieved resolution, the anion gap is closed, the CM bicarb is greater than 20, the BBG is greater than 7.3 on the pH. And then lastly, I bring this up because goals of care discussions are a critical skill for every physician to have. And many times we think of, oh, we're having a goals of care discussion when the patient's about to die or they're having some significant change in their health. But at every level of care, we're doing this. We're doing this in the office when we're offering surgery. We're doing this on consults when we're thinking about taking someone's appendix out. But it's essentially a patient-centric conversation to figure out what their values are, what their preferences are, and what their priorities are. We're trying to align that with what therapeutics we can offer them. In the last decade, in the Journal of Palliative Medicine, this study kind of looked at what are the barriers to having an effective goals of care discussion, and several things kind of came up, like clinician behaviors. If you seem like you're not empathetic, you're not listening, you're not retaining, they're not going to be open enough to have those sensitive conversations. if if their patients are having financial constraints, they're not having a good healthcare literacy, some of those conversations are also affected. If you have cultural or religious barriers, some families come from a background where, you know, offering like hospice or CMO is not even an option in their vocabulary. And so these are all things that you have to kind of navigate as a clinician, as a leader, as a team to have the best care possible for your patients. So looking forward into 2025, Dr. David Ray Velez, who is a traumatologist and intensivist, kind of came up with this protocol called Safe Goals. It's a kind of a neat tool to put it all together and help you have these discussions. So some of these components are first the S, set things up, right? You want to come with a game plan. You want to review all the data. And I think most importantly too, is you want to talk to the primary team to kind of get on the same alignment on, where is this patient's trajectory going? So you don't want to kind of step out in front and be in disalignment with the primary team who's either offering the surgery or perioperatively managing the patient. So that's a key tenet. This is involved in first before this discussion. Figure out how you're going to deliver the news, gather who you need to gather for these discussions, like the nurse of the patient, social work. You can have palliative involved to help you. All these members of the family and the patient to have that conversation happen. And then prior to meeting with the patient, you would want to have a team huddle to explicitly state your game plan. Moving into the A, which is acknowledgement. Start off the conversation by making it personal. You want to introduce everybody in the room. Take a moment for that. Define who's doing what and what the roles are around the table, and be cognizant of how you're letting off to the patient and their family. Be cognizant of the verbal and nonverbal cues. F is family understanding. You want to start off by saying, what is your understanding of what's happened? That's always a good lead off point. So you can kind of take it from there to fill in the gaps understanding. That's what happens in E, which is the events at the hospital course, where you kind of summarize these key events while being honest and direct. G, you want to get to know the patient. You want to figure out, what was important to them? What was their life like before this event happened to them? Is there anything that in life that they couldn't live without? O, you'd want to look at their options, kind of providing options such as code status, therapeutics options, comfort care versus therapeutic care, in many cases, trach peg, as we're consulted on. You want to present those options in a clear manner and show what implications they have in the long term for this patient. All the while you're actively listening, you're responding to the patient and their family, and you're keeping the focus on them. And then lastly, S, which is critical, is to put it all together and summarize, and really be explicit about what the next steps are. If you need to meet again to have another discussion to determine what next steps are, that's a good chance at that moment to be explicit and to state that. And so I just want to bring this up because I know as we're training, this is not something that's inherent. It's actually something that's learned, and it's many times expected on the junior resident to do this when they've only seen it once or twice. So this is something to put in your back pocket as you're thinking about these conversations moving forward. Safe goals. And with that, I keep my presentation succinct and brief, and thank you.
Question for that. I was wondering if you could speak a little bit about patient care, ICU patient. I trained in medicine in the early 90s, and I'm wondering about volume and fluid management. I mean, we're walking this fine line between perfusing kidneys and keeping the lungs, oxygenating. Back then, we were putting Swan-Ganz catheter, and then we decided that was a bad idea. And I think we move to echo to assess volume status, maybe TEE. Where do things
Yeah.
stand now? What's the latest, greatest?
Yeah, again, that's a good question. I think we've moved away from just one use modalities like static, looking at someone's CVP or just depending on one thing. It's kind of moved to a comprehensive look with all the data that we have. In the previous place I trained, we commonly use many of those things conjointly, like I mentioned, like the stroke volume variation. We would look at put an echo on a patient commonly if we're concerned about fluid status and resuscitation. It was part of rounds like quite regularly. So I think where things are headed now is using all your adjuncts together. There's not one defined. You have to have X, Y, Z on every single patient to determine their fluid status, but there's a shift towards using more of those adjuncts that we mentioned.
Is there something here that we depend on more than anything else? Do we do TEs here to assess volume status?
Here,
Again,
in my short time here, no, we don't commonly use TEEs, at least in the surgical ICU. There have been times where I've put an ultrasound on a patient, done a focus to kind of look at some of these things, but like things like Swan-Ganz catheters are kind of getting phased out a little bit in my recent experience here.
A question about tele-ICU. Is there anything you came across that is more structured than how I envisioned tele-ICU? Because I envision it as, someone holding their phone, Zoom call, showing the screen, showing the patient, and some, remote intensivist giving their opinion. But is there anything more structured than that?
It was actually kind of hard to kind of dive into the details of how things are getting like utilized in certain programs. Some of the things I saw in my search were more described as like an iPad or something in the room or some kind of visual component where people are buzzed in and they're viewing patients from afar while also looking at their data from a command center. So I think that's where that kind of plays a role there, but much work to be done to iron it out.
Any other questions? Any questions in the chat? Okay. All right, everyone. Thank you, everyone. Good morning.
Sorry, Brent. Brent?
Sorry, that Lucal, Dr. Lucal.
Hi, I'm so sorry. I could not get myself off of mute. So thanks, Dr. Page, for that. I just wanted to make a couple comments about the pearls and the questions that were asked. I completely agree that we no longer rely on one single number. When I trained, it was the CVP. But now I think fluid status, but I do think that fluid status has changed, right? It used to be in a surgical ICU, you would be 30, 40, 50 liters up because we just kept pounding and pounding with fluid. I don't think that we're as aggressive with fluid resuscitation anymore, but I don't think we're as restrictive as some of our colleagues either. So I do think we've decreased the amount of fluid that we're giving patients. And I think the mentality or the philosophy is that we quote unquote fill the tank. So we make sure that we've given what we think would be an adequate volume based on urine output, which is often a confounder. But labs, the actual number, like if we've given 5 liters, we're usually close to the body volume and we'll sort of stop there. And then we can maybe transition to pressors and allow the body to sort of declare itself, if you will. I think for the residents, I think the one disease process that does not move along in that direction would be pancreatitis. I'm not sure that we really know how much fluid to give and when to stop because there's a persistent capillary leak in those patients, persistent like months. So stay tuned on that because I'm trying to write a chapter on that right now, actually. And then in terms of tele-ICU, this is becoming incredibly popular as throughput and hospital capacity is a problem. A lot of trauma centers are using this within their health system, within their single health system, using the providers that they have. but sort of managing ICUs that are still within their health system. However, there is also not just for ICUs, but for trauma and emergency medicine in general, in these rural areas, to use telemedicine to manage patients that are truly far away and might be too dangerous to transfer them to where they need to be. You can imagine the logistics there that can become difficult, malpractice, billing, etc. Privileges. Some of these places are managing patients in other states, so licensing, etc. And then finally, palliative care. Palliative care is a passion of mine, if you will. And I agree with Dr. Page that it starts from the moment the patient hits the door. I think what goes along with that maybe is just being a good doctor, but trauma-informed care, not physical trauma, but what has this patient gone through? What has this patient been going through that may impact how they approach their current care? And that could span something like physical, abuse, to I've been in and out of hospitals so many times in the last 2 years, I'm done. So there are a lot of great one-page, that was sort of the shtick, one-page ways to approach palliative care depending upon the situation, and they're all on the AAST website, and they're fantastic. So I encourage the residents to sort of look them up. I think a couple of them are hanging in the TICU. So sorry to delay everyone's morning. I just wanted to get those thoughts out of my head. I couldn't get off mute earlier.
Thank you.
All right. Thank you very much. Thanks, everyone.